our today's speaker. Today's speaker is a man of charismatic personality and is a social media sensation with huge national and international fan following, and is a very powerful speaker. He is currently serving as a senior faculty at NICBT Karachi. Please welcome Dr. Faward Farooq.
Such a nice and generous introduction. Heart failure is something which is expected to increase day by day. And why is it so? That we have very improved management strategies for MI, which is the main source for really increasing the pool of heart failure patients in future. And especially from any structural or functional cardiac disorder that impairs the ability of ventricle to fill with or eject blood. It's not just ejection or pumping activity. It's the filling as well. And filling is a very important cycle in a cardiac cycle, that diastolic phase where your heart receives blood and relaxes. So that's why heart failure nowadays is divided into these three categories: HFpEF, HFrEF, and HF marginally reduced ejection fraction. And there is one category in which patient recovers after heart failure. That's sometime in myocarditis, in pericardial cardiomyopathies, and this is the fourth category. But out of these three categories, we have to consider all these three as heart failure. Heart failure is not just inability of heart to pump blood. Why is it important? We'll see in the stages of heart failure as well as management of heart failure. Today we just focus on this part, reduced ejection fraction. Systolic heart failure is a clinical syndrome usually due to LV systolic dysfunction, EF less than 40%. When we say about systolic heart failure, always usually I see my juniors, they just diagnose heart failure. That means the job is done. Job is not done, it's a syndrome. You have to look for what's behind, and we'll see what are the background things you have to look for when you are facing a patient of heart failure for proper management strategy. It's not just pulmonary edema. A number of times you see the discharge card is showing pulmonary edema, LVF. That is the diagnosis. This is the clinical syndrome you have diagnosed. You have to pick or really judge a lot of more things in this heart failure patient to manage this patient properly. I'm just going quickly through these things: causes, symptoms we all know, signs we all know that we have to look for. Then after this clinical presentation, we usually do ECG and X-ray for further assessments. Some blood workup is needed, that is renal function, electrolyte, CBC, BNP levels nowadays incorporated into the workup of heart failure patient for sake of exclusion purposes. Then after that you do LV assessment or echocardiography for further confirmation of your diagnosis. And this 2016 algorithm given by European Society of Cardiology, and this is for non-acute onset heart failures. What you do, assess heart failure probability, because heart failure patient doesn't come saying that I'm heart failure. You'll be coming with signs and symptoms where there will be an overlap. You have to first judge, are you dealing with heart failure or not? And for that, you need a good clinical assessment. And this clinical assessment is not for sake of just diagnosing heart failure. Your clinical assessment should be looking after the etiology of heart failure, aggravator of heart failure. That's important for management purposes. Usually what we see, people just diagnose heart failure, pulmonary edema, Lasix ke short, patient set, 3 drugs, beta blocker, ACE, diabetic, that's it. heart failure pulmonary management. It's not that easy. So you have to go through a comprehensive clinical history, physical examination, then ECG. These three things should be done immediately. After that, and that is for non-acute. When you are dealing with an acute heart failure patient, again, is this heart failure? Is there a precipitant? And is the heart failure immediately life-threatening? Hypoxia, patient going into shock with vital organ reperfusions problem, dysfunction, renal. So that is also important when you are looking at an acute heart failure patient. One thing also important regarding acute one, that you have to differentiate acute and a worsening heart failure. Worsening heart failure is just a deterioration in pre-existing diagnosed patient. And usually this patient is easy to manage. You may found a precipitant, take care of that precipitant. You will be okay with management. And sometimes this patient doesn't need admission as such. If you found a precipitant, and common precipitant is non-adherence to drug, excessive water and fluid intake, infection. You take care of that, within few hours these patients got stable. But when you are doing a new acute heart failure, that is something different. Sometimes even this acute heart failure may be due to acute ischemia. And MI is sitting there and you're not doing ECG, just managing heart failure. So you have to make a difference in these two and do your workups and assessment and management accordingly. Common precipitating factor that we will be discussing in worsening heart failure, medication non-adherence, not adherence to sodium and fluid intake, use of NSAIDs, concurrent infections, arrhythmias, atrial fibrillation, and sometimes these atrial fibrillations are paroxysmal, and as so that the patient when come to ER, he may be in sinus rhythm. He had 1 or 2 hours of palpitation and dipped into from stable to unstable, and in ER he's in sinus rhythm. If you haven't picked, sometimes you have to do holters and other things to pick this paroxysmal AF as a precipitant of heart failure. Then anemia, endocrine abnormalities, uncontrolled hypertension. These all things are very important when you are managing your heart failure patients, especially the one who are coming with worsening heart failure. Because a number of times when I ask my juniors in round, what's the diagnosis? It's a heart failure. These patients, EF 35% is the diagnosis. This is something with him for the rest of his life, even pre-admission and will remain post-admission as well. You have to look for precipitant and this time the reason for admission in this heart failure patient. And a number of times ischemia, we miss arrhythmias, infection, these are something which told themselves, fever, cough and other. But these things are hidden that you have to look for. Because if you haven't taken care of these precipitants, this patient will be again after 1 month in the ER with pulmonary. That stages of heart failure is very important. Why am I mentioning that? Right now we have discussed the classification, HFrEF, HFrEF and marginally reduced EF. Now stage A, just look, what is stage A heart failure? The risk factors for heart failure is stage A heart failure. Meaning by a hypertensive patient is not just hypertensive patient. He is a stage A heart failure patient. Diabetic is not just diabetic. He is stage A heart failure. So just start looking at your patient when he is having just risk factor as a patient or potential patient of heart failure. And it's time to start your strict management here to slow this progression from stage A, B, C, D, so that your patient may went into stage C at like 60, 70 years, but unfortunately, we see our patients at the age of 35, 40 years in this stage C, after managing him with primary PCIs as well. And unfortunately, even after developing stage C, we don't take care of them properly with proper managements or proper drugs with proper dosages, and have stage D even in 45, 50 years of age. And that's very important to understand these stages. At every stage when you found your patient, very aggressively manage him to prevent from going from stage A to stage D. D is you have some effects on heart, but patient is still asymptomatic. C is asymptomatic heart failure, and D is resistance or refractory heart failure. So that means within this background, you have to fulfill three objectives when you see a patient who is expecting a heart failure. Is you have to diagnose heart failure, you have to look for etiology and aggravating factor, and you have to define the stage of heart failure in your patient. These three things should be looked in every heart failure patient, and that's the algorithm. These three things, after clinical history, physical, and ECG, you are suspecting heart failure, get NT-proBNP done. If it's negative, it's less likely to have heart failure. But if it's positive, you need echocardiography. A number of times we don't do this proBNP. We after this directly go to echocardiography, usually. But this is part of algorithm for sake of exclusion purposes. When it's positive, it may be other things as well. But it helps you in future in patient management, looking for this stability and instability. So this NT-proBNP do help you in future. Now let's start with this background case scenarios to incorporate whatever knowledge we have really got from this all background, how to approach a patient with heart failure. Let's see a 50-year diabetic female with occasional exertional shortness of breath for 1 month. So that's something patient which can be anything. It can be anemia, it can be a chronic lung disease, it can be just a functional deconditioning. But since this patient is diabetic, so that is raising question, because diabetic means stage A heart failure. She's already in stage A heart failure. And now she's coming with symptoms which you may have in heart failure patient, but these symptoms can be in other conditions as well. So you need a workup. Workup means those three basic things: history, examination, and ECG. So that means with any symptoms consistent with heart failure with a potential risk, you should be doing these three things. They will guide you towards somewhere. So what next? We know that we have to do history, examination, and ECG. History part, we all know that you have to go through. These points should be covered in history. History of CAD, revascularization, arterial hypertension, exposition to cardiotoxin, drugs, radiation, diuretic use, arrhythmia, PNG. These all again with those three objectives: diagnosing heart failure, etiology, and stage. These are the outcome after your history and physical examination. Along with diabetes, she is hypertensive with history of an episode of sweating, chest heaviness for a few hours about 2 months back with normal examination. Now what this suggests? Anyone? This background, this information, are they really raising red flags in your mind with this workup? Sadly. Because a diabetic with something happened to his chest, maybe an old MI, is silent. So this is the ECG. And so this will actually things really, when you search for them, you found them. If you just casually go through things and manage them casually, you haven't found the clues. Here you can clearly see Q waves in inferior leads. Here. So certainly this history is matching with this ECG that she may had a past inferior wall MI, and now since that happened after 2 months, and now she's having the consequence of that MI, maybe going into failure. So now what's the next step? After these 3 things, ideally anti-pro-BNP. She's in stable patient, you can do to look for, but ideally echocardiography we usually do at this stage. According to algorithm, anti-pro-BNP, and if it's positive, yes, then echocardiography. And echocardiography showing ejection fraction 35% with akinetic inferior posterior wall. So now you are at least went to your second stage, that this patient is in heart failure, like stage C probably, because she is symptomatic, with the background maybe ischemic heart disease. And the precipitant, since she wasn't diagnosed previously, it was all undiagnosed patient coming with symptoms. But do you think this thing is stopped here, or you need further workup? We'll come to management part. I'm stopping here, just assessment part, and going to our second scenario. I'm lucky I have 30 minutes. Usually I do my presentation 10-15 minutes, so I'm feeling very relaxed with 30 minutes for this presentation. Objective of evaluation, diagnose heart failure, etiology and stage. So in this patient, she is a heart failure patient, stage B to C, etiology, IHD or diabetes. What we need to define a treatment strategy with future workup plan for her. That we'll do after our management strategy. That is another case. 70 years diabetic with severe shortness of breath for a long period, aggravated since 2 weeks. Severe shortness of breath for a long period, aggravated since 2 weeks with orthopnea and PNP. That's a brief outcome. But you need further workup. Again, history, examination, ECG. These 3 things are obligatory in every patient who's coming with symptoms of heart failure. And since this is an acute kind of heart failure, you have to look for this acute part as well. Is this heart failure immediately life-threatening? Are they precipitants? And that you usually look both in acute and non-acute onset. That we already have discussed, worsening heart failure and acute heart failure that you have to differentiate in your patient. This is a kind of worsening heart failure because he has a background of MI as well. Case 2, after history examination, history of MI 5 years back, no record available. His non-compliance to treatment, heart rate 130, irregular, blood pressure 90, 70, normal vesicular breathing with inspiratory breaths all over. What you are getting from this information? Etiology, probably ischemic heart disease, already mentioned. What's the precipitant? Anyone? Any junior? Probably arrhythmia, because here your pulse is giving. So it's not just examination, a stat or chest pick reps. That's the examination of heart failure. Keep an eye on etiology, aggravators, all aggravators which you can pick on your clinical judgment. That's the third part, ECG. Now what this ECG is telling about this patient, with this background, brief information and combining this ECG with his clinical information, what you can make out, because there was a history of MI, but there wasn't any record available. Can you make out anything from this ECG? Anterolateral wall MI probably in the past. Usually it's anteroseptal because you have Q waves from V1 to V3. Here in V4 to V6 R are preserved. So it's probably anteroseptal MI. With aggravator right now is atrial fibrillation with fast ventricular rate, which has precipitated for last 1-2 weeks. So now we will come to management at the end.
About LVH?
LVH.
Yeah, LVH is agreed.
Adult aortic stenosis.
Yeah, there is LVH. So again, 3 objectives: diagnose heart failure, etiology and exacerbating factor and stage of heart failure. In this patient, echo showed this was expected. Now when we come to management, you have to consider the pathophysiology. We all know that there must be something at this side of spectrum, that is stage A, hypertension, diabetes or anything which can affect heart, or ischemic heart disease, maybe drugs, and some less common things, pregnancies or other, that should be in your mind when you are seeing a patient with symptoms leading to myocardial injury, pathological remodeling, neurohormonal modulation, toxicity, logic infection, symptom and ultimately death of the patient. And when it comes to drugs, actually drugs are taking care of that pathophysiology which is compensating this heart failure journey by means of renin, angiotensin, aldosterone, sympathetic output. This all is for sake of preserving heart function. When you have low perfusions, these all mechanisms start acting to maintain perfusion. And they certainly, when overshoots, they are not giving benefit. They are causing harm to your patient. So the objective in all management of heart failure is to bring or keep this mechanisms within the beneficial threshold. Neither too low, sympathetic activity खत्म कर देंगे तो patient hypotension और shock में चला जाएगा. Heart rate बिल्कुल slow कर देंगे तो cardiac output effect हो जाएगा. So you have to keep a very good balance of your management to keep this mechanism working and preventing it from overshooting. And that can only be done with proper assessment at every visit of your patient. कभी आप अंडर यूटिलाइज करेंगे अपने आर्मामेंटेरियम को, कभी ओवर यूटिलाइज करेंगे. अगर आप हर विजिट पे अपने पेशेंट की ब्लड प्रेशर, पल्स रेट, वॉल्यूम स्टेटस, इन तमाम चीज़ों को सही से असेस नहीं करेंगे. And that you do with these drugs. Beta blockers taking care of sympathetic activity, ACE inhibitors taking care of your renin, angiotensin, ARBs. Now you have further more newer RNAs and even SGLT2 inhibitors. We'll see in the updates as well what are the new. These are the conventional drugs which we were using for heart failure. That stage A, B, C we already have discussed. When we start managing our patient with stage D, taking care of risk factors, whenever they have symptoms, taking care of those symptoms. ACE inhibitor, beta blocker are usually given at stage C, but if you have a risk factor of hypertension or other where you have a compelling indication for these drugs, even you start from stage A and B. Diuretic according to symptom, and stage D you do palliative therapies and assist device. That we'll discuss in another algorithm. That you have to correlate your stage and functional class together. So always keep an eye on your patient's stages and his NYHA class as well whenever you are assessing your patient. That's a busy slide, but giving you a comprehensive outlook of the management strategy, since we have to come back to our cases as well. So I'm just giving you an overview of management. Step 1, you start with your conventional management, ACE or ARB and guideline directed beta blockers. Diuretic as needed, that is again very important. We once discharge our patient on 80 milligram of furosemide, then it continues for the rest of the life. That shouldn't be. It's all depend on your patient volume, status, his blood and salt intake. If he is really managing his balance even without diuretic, he may not needing diuretic at all. So diuretic, especially the loop diuretic, they are all volume dependent. Aldosterone antagonist surgery is a modifier that can be given, but loop diuretic should always be assessed with dose of loop diuretic according to the patient volume status. Step 2, after this conventional medication, If still your patient is in stage class 2 to 4, but his creatinine clearance is adequate and potassium is less than 5, you can offer aldosterone antagonist. That is also very important. Number of times we start these two, ACE/ARB and aldosterone antagonist in a patient who's renal compromised and never bother about potassium. You have to check a baseline potassium and check after week as well. And once your patient is stable, monthly potassium checkup should be done in this patient. Because just giving a slight benefit of morbidity and mortality, you may give death to your patient with lethal arrhythmias of hyperkalemia. So it's very important, especially when you're giving aldosterone antagonist without furosemide. It's very important to keep an eye on potassium. Second, if your patient is still in 3-4 adequate dialytic ACE or ARB, RB. But this was 2017 guidelines. Now the new update is that out of all of these three, you can start any as your first option, RB, ACE or ARB. In class 3 and 4 in black patient, that is for Americans, hydralazine nitrate combination can be added. Still 2-3 less than 40% ICD, but with broad complex. Or after MI, 40 days post MI, you can give, that is for less than 35% post MI patient. 40 days ICD can be offered, that is for primary prevention. 35% QRS broad can offer CRT. Heart rate still high in spite of your optimum beta blocker, then you can give evaporative. But remember, after adequate beta blocker, or if your patient is not tolerating beta blocker. This is not something that just low dose of beta blocker and adding evaporating. If your patient have pressure, increase the dose of beta blocker first. Evaporating is only when your patient is not tolerating beta blocker, especially in heart failure. Then step 4, refractory NYHA class, still symptomatic after these. Then you can offer these all things, palliative care, transplant, LV assisted device, and these are the updates regarding a few new things that are coming up, in which I'll mention here SGLT2 inhibitors. They are for patient meeting GFR criteria and still in NYHA class 2 to 4. You can give SGLT2 irrespective of diabetes. Similarly, as I already have mentioned, this is 2021. RD, ACE or ARB, out of these three, anyone can be offered at stage 1, initially stages. Rest are almost similar. Few tips about stage D. Sometimes we prematurely label our patients stage D without proper assessment and management. Advanced heart failure, stage D heart failure, classification scheme, which is defined as refractory heart failure that requires specialized intervention. Further GGMT modification are not possible. When you can't further really up-titrate your medication, that's the stage when you label your patient stage or refractory heart failure. And usually these are patients who are hypotensives with volume overload. Now you can't do anything. They don't have pressures. You can't really up-titrate your ACE or beta blocker. Even sometimes you give diuretic, they drop their pressures. But that is patient with advanced heart failure have persistent or progressive advanced heart failure symptom despite optimized guideline-directed medical therapy, including drugs and devices. That you have gone through that option of CRT as well, you have done ICD as well, you have done all the things, and still your patient have symptoms. Then you label them as stage D or refractory heart failure patient. That's the course of this disease. And that's why it's very important to pick your patient at stage A and start managing aggressively at stage A. If you have missed, you have stage B, still missed stage C, try to prevent him going to stage D. It's a very difficult stage, very difficult. 50 to 60% mortality, a very morbid kind of life, constant symptoms, repeated admissions. Let's come to our patients with all that discussion. Diabetic female, you may be remembering, just a recap. Along with diabetes, she is hypertensive with history of an episode of sweating, chest heaviness, few hours. That was the ECG. How will you manage? Previously, she was just diabetic and hypertensive. Looking at this strategy, she was taking just anti-hypertensive and anti-diabetic. Considering a background of ischemic heart disease, she needs antiplatelet, she needs statin, and she needs workup for potential ischemia. She's a young patient. If she's if she's asymptomatic, you need a perfusion scan to see for viability or potential ischemia anywhere. And we have seen a lot of silent ischemic heart failure patients just managed for heart failure. They have never been looked for potential ischemia. And we see them after 1-2 years with an MI with very, you can say, less myocardium left. And this young lady, if had another MI, she may be in refractory heart failure very soon. So any young patient, even in old, at least potential ischemia should be looked on if you are considering an etiology of ischemic heart disease. Coming to second case, here you need some acute management as well. This patient was having, this was the status, and his blood pressure was 90/70. Can anyone tell some tips about acute management of this patient? Now he is in frank pulmonary death and shortness of breath severe with a background of anterior MI, AF with fast ventricular rate, and failure with blood pressure of 90/70. What should be done? Rate controlling, diuretic, and rate controlling you can't give beta blocker in a heart failure patient with low pressures. Options left, either digoxin, or even if it's really causing shock state, you may cardiovascular transfusion, even without prior point depopulation, because this is an emergency cardiovascular. But future you need an adequate medication for this. Thank you for your patience.
Thank you very much, Dr. Fawad, for your very elaborate talk. Now, in the interest of time, I'll take a few quick questions, 1 or 2 quick questions.